All right, let's dive into a topic that is genuinely one of modern obstetrics' greatest triumphs: RH alloimmunization. Look, understanding these protocols isn't just about passing your boards, it's a core part of our daily practice that has saved an incredible number of lives. So let's break down exactly what you need to know in this high yield review. So here's our game plan. We're going to start with the fundamentals, the what and the why behind the whole thing. Then we'll cover our best weapon, the standard prevention protocol. From there, we'll pivot to what to do when a patient is already sensitized. We'll look at our modern tools for surveillance, and we'll wrap up with some crucial exceptions, like that tricky KEL antibody that you really can't afford to miss. Okay, first things first. Before we can talk about how to manage this, we absolutely have to be on the same page about the basic mechanism. So what is alloimmunization really? At its core, alloimmunization is just the immune system doing its job, but at exactly the wrong time. An R-negative mother's body sees her Rh-positive baby's red blood cells as foreign. Now, that first exposure, usually during delivery or another event, it doesn't actually harm that first baby. Instead, it's like a training mission for her immune system, priming it to build an army of anti-D antibodies that are ready and waiting to attack in any future Rh-positive pregnancy. Now, here's a really critical point. Not all antibodies are created equal in this fight. The whole reason we worry about this comes down to one simple biological fact: size matters. The antibodies that cause all the trouble, like anti-D, are IgG. They're small, they're nimble, and they can sneak right across the placental barrier. On the other hand, you've got your IgM antibodies, like Lewis or anti-I. They're big, they're clumsy, and they get stopped cold by the placenta. So the take-home message is simple. IgG gets in, IgM stays out, and that's why we focus so intensely on IgG. So if that's the problem, how do we stop this immune cascade before it even begins? Well, that brings us to our number one goal: prevention. For an unsensitized Rh-negative patient, this isn't just another tool. It's the absolute game changer that has completely revolutionized outcomes. The modern protocol is this brilliant three-pronged defense. First, we give a routine dose around 28 weeks. That's to cover any tiny, silent bleeds that might happen. Second, we give another dose postpartum within 72 hours, but only if the baby is confirmed to be Rh positive. And third, this is key, we give it after any potential sensitizing event. The impact of this simple strategy has been just astounding. It's taken the rate of alloimmunization from around 16% down to less than 0.2%. Incredible. So what exactly do we mean by a sensitizing event? Think of this slide as your high-yield, must-know checklist straight from the ACOG guidelines. We're talking about any pregnancy loss, any significant bleed, any abdominal trauma, or invasive procedures like an amnio or CVS. Even an external cephalic version is on the list. The rule of thumb is simple. If there's any chance whatsoever that fetal and maternal blood might have mixed, you give anti-D immune globulin, period. And here is the magic number, the one you need to have burned into your brain for your exams: 300 micrograms. This isn't just some random number, it's very specific. It's calculated to neutralize up to 30 milliliters of fetal blood, which is more than enough to cover the vast majority of sensitizing events we encounter. Okay, so while 300 is our standard, there are a couple of nuances. For a first trimester loss before 12 weeks, a smaller 50 microgram dose is fine, though giving the full 300 is also perfectly acceptable. After 12 weeks, it's always the full 300. But here's the most critical point on this slide. If you suspect a large hemorrhage, we're talking major trauma, a placental abruption, a fetal demise, one standard dose might not be enough. You absolutely must quantify the bleed, usually with a Kleihauer-Bedke test or flow cytometry, to see if additional doses are needed. This is a crucial safety step to prevent prophylaxis from failing. But what happens if prevention fails, or a patient shows up for her first visit and she's already sensitized from a prior pregnancy? Well, this is where our entire strategy has to shift. We move from prevention to active, intensive surveillance. The whole game changes. So the very first thing we do with a sensitized patient is check her antibody titer. But that immediately brings up the most important question. At what point do we start to really worry? What is the critical titer? The critical titer is basically our clinical alarm bell. It's the level where the risk of the really bad stuff, severe fetal anemia, hydrops fetalis, becomes significant. Now, the exact number can vary a bit between labs, but it's generally going to be in that 1 to 8 to 1 to 32 range. Once a patient's titer hits that threshold, that's our signal to escalate care and begin much more intensive fetal monitoring. So the management algorithm is actually super logical when you break it down. Step 1, as long as titers are low, we just keep monitoring them every 4 weeks. But step 2 is this fantastic potential off-ramp. We try to determine the fetal Rh type, if the father is Rh negative, or we can confirm through cfDNA or an amnio that the fetus is Rh negative, then we're done. There's no risk. But if the titer is critical, and we know the fetus is Rh positive, or we just don't know, then we have to move on to step 3, full-blown fetal surveillance. And that brings us to surveillance. For that high-risk fetus, our job now has one single-minded focus. We have to watch like a hawk for any signs of developing fetal anemia. You know, it wasn't that long ago that monitoring meant putting these patients through a series of invasive amniocentesis. But thankfully, the standard of care today has shifted to something much better and totally non-invasive, using Doppler ultrasound to measure the peak systolic velocity in the fetal middle cerebral artery, or MCA. The physiology here is actually pretty elegant. As a fetus becomes more anemic, its blood gets thinner, less viscous. So to keep oxygen delivery up to the brain, the heart has to pump that thin blood faster. And we can actually measure that increased speed in the MCA. Once that velocity crosses our action threshold, which is greater than 1.5 multiples of the median for that gestational age, it's a very strong predictor of severe anemia. That's our cue to pick up the phone, call maternal fetal medicine, and start talking about a potential intrauterine transfusion. All right, let's talk about the endgame, delivery. The timing is a really careful balancing act, and it's tailored completely to how severe the disease is. As you can see here, for mild cases, we can often push for term, aiming for 37 to 38 weeks. But for the severe cases, the ones requiring transfusions, the equation flips. The ongoing risk from the alloimmunization becomes greater than the risk of prematurity. In those situations, we plan for an earlier delivery, usually somewhere between 32 and 34 weeks. All right, for our last section, let's talk about the exceptions, because while we've been focusing on anti-D, it's not the only bad actor out there. And it's absolutely critical to know that some of the others, especially one called anti-Kel, play by a completely different set of rules. And here it is. This might be one of the most important takeaways of this entire review. With anti-Kel, maternal titers are completely and totally unreliable. This is a classic board question because it is a massive clinical pitfall. Why? Because unlike anti-D, which just destroys red blood cells, Kel does that, and it actively suppresses the bone marrow from making new ones. This means you can have a profoundly anemic baby with a deceptively low maternal titer. So the rule is absolute. You see anti-Kel, you ignore the titer, and you go straight to serial MCA Dopplers. Finally, just keep these other players on your radar. Antibodies like anti-C, the other Rh antibodies, as well as Duffy and KID, they can also cause significant hemolytic disease. The good news is, for the most part, you can manage them just like anti-D, using that critical titer as your guide for when to start getting worried and begin surveillance. And that really brings us full circle. This quote from ACOG says it all. The near elimination of severe Rh disease isn't because of some single miracle drug. It's the result of decades of clinicians just like us systematically and consistently applying the protocols we've just walked through. It is a powerful reminder that sticking to these simple guidelines is what truly saves lives. So I'll leave you with one final question to think about, looking towards the future. Right now, we give prophylaxis to every single Rh-negative woman. But we know up to 40% of them are carrying an Rh-negative fetus, meaning they don't even need it. As non-invasive fetal DNA testing gets better, faster, and cheaper, could we see a major shift? Could we move away from universal prevention to a precisely targeted approach, treating only those who are actually at risk? It's an interesting thought about what the next chapter of this incredible story might look like. Thanks for joining me.